You've heard from the gurus on a lot of the technique stuff. So I'm going to try to focus on the when to do it, why to do it, and when not to do it sort of message. But we'll go over a little bit of the data too, because I think that's important in laying the foundation of your choice to embark on doing a lateral reconstructive surgery, and particularly the ACR. So when we talk about deformity, we're trying to achieve a desired correction. Sometimes that's a little surgery, sometimes it's a big one. But it's important to keep in mind that we're starting to realize that there's some normative values for age that you can start shooting for. And overcorrection can be problematic. So going for 30 degrees is sometimes not what you need. You need to go for the 20. And also, obviously, minimize the complications getting there. That's both intraoperatively as well as downstream. A lot of the failures that occur happen 2-3 years down the road, and that is not just with the big open posterior stuff. ACRs can suffer the same fate. So technically, we'll talk about some of the things you do posteriorly to limit that. Durability outcomes is important, and obviously optimizing the cost efficiency of the whole process. So when we start talking about how you tackle these problems, the first and most important thing is whether you're dealing with a fixed deformity that's postoperative or ankylosed, or you have a flexible deformity, and that'll dictate how you approach it. If you see a spine like this, where you have a clear ankylosing type of condition, that may not be your best recipe for an anterior column release, at least not right out of the gate. You might have to plan some work in the back if you're going to go to the front and do that in preparation for the anterior column release. We typically like to use some dynamic radiographs or a comparison between the upright and the supine advanced imaging as a marker for flexibility at the segment that we're going to try to realign or do an ACR in particular. If it's not moving at all between those images, then we start getting worried and looking further into why that might be the case. Sometimes it's ankylosed facets, sometimes it's ankylosed disc space. Either way, it introduces a level of complexity and potential complication that you don't want to have. In terms of options for sagittal correction, there's a bunch out there. You know, we talked a lot about lateral and ACR, but don't forget there's a lot of other ways to fix these problems, particularly in fixed deformities. And just laying patients prone, you can get 18 degrees on average of realignment. So looking at a standing lateral image is not a good arbiter of what you're going to be able to achieve just putting a patient prone. And if you have a relatively mild amount of deformity, you may not need to be heroic with what you're going to do. You have ALIFs, ACRs, anterior osteotomies, posterior-based osteotomies, and really the key is trying to figure out where we can reduce the risks and the complications in deploying these technologies. And so initially we looked at MIS and tried to basically establish a little bit of an algorithm as to when we could deploy these various techniques. And this is really just sort of a Delphi technique, getting some consensus amongst experts or so-called experts in MIS deformity. And this is our first go at it, trying to algorithmically allow us as well as everybody else to figure out where the MIS approaches fit into fixing deformity. So you can see here you have 3 different classes, and you follow yourself down based on basically the degree of the deformity, whether it's a flexible curve, so back to the fixed and flexible aspects, the degree of deformity again with an eye as well on the thoracic kyphosis and quantity of it. And then that sort of filters down to where you can get away with some MIS surgery and where you have to go to open surgery fully and more traditional osteotomies. This is our now 5-6 years ago. And in that context, we looked at where in using these techniques, we were having ceiling effects, where patients were struggling for the amount of correction that would be ideal for their age normative values. And we looked at standalone and circumferential MIS and found that there was a limited capacity with those original techniques to change pelvic tilt, which is a primary driver of disability profile with spinal pelvic parameters, and SVA, which we all know to be a big driver of disability. So the initial techniques were not quantitatively capable of driving the kind of change we needed for optimizing outcomes. That was the bottom line, or at least we had a ceiling effect for some of the MIS techniques. Now, that was, again, with kind of lateral approaches, early MIS T-lift kind of stuff. So if you look at this, you go further into this same group of patients, patients with really high SVAs tended not to improve much, and moderate sagittal plane deformities had some improvement. So we're getting to a place where we need to evolve the techniques and getting beyond just laterals to ACRs. So ACR hits the ground running, and the possibility of a posterior-based anterior column release, mini-open A-lifts with more aggressive release in hyperlordotic cages, and now mini-open posterior column osteotomies, and even mini-open PSOs. So now we're bringing a lot more heft to the MIS sector in terms of how we can correct the deformity much more aggressively. Now, taking a step back, I think it's important as you think about each of the techniques that we have at our disposal to have a basic sense of the range of correction. So this is a little bit of a matrix to keep in mind in terms of how each of these techniques plays a role, and you mix and match them based on other issues or factors within the patient you're trying to prescribe treatment. So, obviously up at the top, you have posterior spinal fusions, and you're not going to get much change there. T-lifts, splits don't affect much change without the use of facetectomies, or essentially a posterior column release on top of that. And then you can affect some significant change. Laterals have quite a range, and that depends on other issues with respect to cage position, cage alignment, and what you do on the backside, and all the way up to ACRs. And as Bill Smith mentioned previously, the ACR even has quite a range in corrective capacity based on what you do on the backside. And it also has a lot to do with the level at which you treat. The normative level, or I'm sorry, the normative alignment of the level will change relative to the cephalad nature of it or the caudad nature of it in the lumbar spine. An L4-5 level wants to be at 15 degrees and won't sweat much to go to 20. You try to put a 20-degree cage without a pretty aggressive release or even some work on the back at L1-2 or T12-L1, you're not going to get it to soften up to that 20 degrees. So you have to do a bit more. The cage positioning is important. You can see in this nice example, when you put the cage posteriorly, you tend not to get much lordosis. The posterior intervertebral height blocks you, whereas if you put it more ventrally, you tend to get more. So as you think about lateral reconstruction and realignment, it's not always critical to release the ALL. If you're thoughtful about where you position the cage, sometimes use a thinner cage, you can actually create a fair bit of change, up to 20, 25 degrees, simply with a standard lateral well-positioned and a posterior column release. And in some cases, that may be more feasible than trying to go through an anterior column release fully. If you talk about indirect decompression, and that is a priority, then you have sort of an opposite effect. So you have to factor these two issues in when you are prescribing the realignment and neurologic scenario for the patient. Lateral cage position, if you look at it, has an average increase in lordosis of about 3.7 degrees based on the literature, and you have less preoperative lordosis, but more gain in lordosis, depending on where you put the cage. Anterior placement, 7.4 degrees, posterior placement, neutral to minus 1.2 degrees. So big difference depending on where you're placing the cage. We talked about the nature of where you place the cage and what its sort of normative value wants to be, and that will influence how much work you have to do dorsally. So in terms of now moving on to these much more significant malalignments, you can see here a very significant focal kyphosis and a corrective maneuver with an ACR. Remember, prone positioning increases the lordosis, and when you release the ALL in these sorts of scenarios, especially if they're floppy, and you don't secure it, you run the risk as you go to the back, releasing the spine with a posterior column release of a very destabilizing 3-column injury mechanism, and you will swing to more than 30 degrees before you know it. You'll be at 40 to 50 degrees of segmental lordosis. So you have to be thoughtful about that. And as you see here, there's only one screw in the tab right here. That was a matter of some debate, and I think it probably still is. I will tell you that we tend to put screws above and below now to restrain the spine from swinging open farther than we want it to, because we're using a 30-degree or 20-degree prescription on the front end, and if it flies open, it's very hard to capture it again, to get it back down to the degree that you had wished it to be. So I would tend to use both screws, be thoughtful about the positioning of the caudal screw because of the screws you may be putting in the back. As we started using this technique, initially it was somewhat serendipitous, but as we deployed it, we started comparing the technique with the PSOs and just ascertaining how much correction we got. And you can see here nicely relative to 3 good studies on PSOs that our degree of correction was equivalent. And then we looked at the lumbar lordosis in a matched group of deformity patients, and you can see here that lumbar lordosis postoperatively in both ACR groups and PSO groups was maintained at 1 year in both groups. And there was no difference between the PSO and ACR groups at that year mark. Pelvic tilt was really only improved in the ACR group, interestingly, not the PSO group. Now, that's going to be subject to where you place your PSO. Long history of PSOs has kind of led us to L3, L2 PSOs. That drives your pelvic tilt less, correction less, than putting an ACR at L3-4 or L4-5. So where you have your correction will impact that pelvic tilt number significantly, but at least in the data set we had, ACR looked like it might have an edge at pelvic tilt improvement. And so from that study, we found that there were relatively similar radiographic corrections, maybe an edge for pelvic tilt correction with the ACR, and a lot less blood loss with ACR. The complication rates at that time were considered equivalent. Arguably, you can debate whether the complications with ACRs are equivalent. You know, we're capturing thigh dysesthesias and hip flexion weakness as complications versus PSOs, which tend to be a little more disastrous complication. Diving into a little bit of data, because I want you to have the foundation for the ACR solidly. The complication neurologic deficits following ACR, and this is one of the early retrospective studies by our colleague Juan and his group, and you can see here from 2000 to 2015, a fairly small number. This is early in the process of the learning curve, an average change in lordosis of 17.6 degrees and 19% major complications, which again were iliopsoas weakness, only one of which was permanent or sustained, and 1 retrograde ejaculation. We, in our group, looked at ACRs and adult sagittal deformity, and you can see here that there was about a 17 to 27 degree average segmental correction. So not always 30 degrees, some of these are 20, some of these are 30-degree cages. And it was quite recognizable that you'd get greater segmental correction if you added the posterior column release. Is that necessary in all cases? No, but understand that you may need to do that. The lateral procedure alone without an ACR only achieved about 6 degrees of correction segmentally. And that was not necessarily corrected for posterior column releases. If you look at the same type of scenario, this is this is a later comparison between ACR and PSO. So 2 good ways to correct sagittal deformity. These are matched cohorts. You can see that pelvic tilt only improved in the ACR group, and this is a 34 to 25 degree change, and then 31 to 28. EBL was lower again. And then finally, this is the Italian group. This is also early in their learning curve, 11 patients, 27 degrees of segmental change, and 2 major complications in that group, one of which was posterior-based complication not related to ACR, and one of which is just approach, not necessarily related to the ACR. So the summary of what ACR can achieve for you is that about 50% correction of segmental angle with ACR alone without any other work done is kind of what you plan for. Sometimes you'll get more if it's a real floppy level, but don't go in thinking you're going to get 30 degrees without doing some posterior work. There is some variance based on segmental angle, native to that part of the spine, and there tends, as a result, to be greater change segmentally in the lower lumbar spine versus the upper lumbar spine. Ankylosis reduces the capacity for change. If the facets are ankylosed, the anterior column's really ankylosed, it's going to fight you, and you run more risk of fracture. So there are cases, if you look at the preoperative CT, that you may think about going to the back and releasing before you go to the front to do this. In fact, some of the centers do that on a universal basis. You tend to get 100% correction, with the, in terms of angular realignment with the posterior column release. So now we kind of returned and looked at what our capacities were for MIS deformity correction based on the evolution of techniques. And even this, I think, will change over the next 5 to 10 years. But essentially now we're doing long fusions with higher degrees of deformity now in this class 3 section with the use of ACRs, mini open PSOs, which you can add to an ACR, or many open PCOs with the ACR get very significant sagittal realignments that we didn't otherwise think were possible. In terms of planning, that's where the rub is, I think, primarily. Your L4 to S1 versus upper lumbar and thoracolumbar junction needs to be scrutinized in terms of where your deformity really is located. You know, if you have in this case, you have multi-level degenerative disc disease on the left and kyphosis that's pretty pervasive in the lumbar spine, you can kind of pick your poison, but you want to try to get some harmony to the lumbar lordosis, so you could do ACRs lower in this case. And yet, if you look at a case on the right where you have a postoperative condition of iatrogenic flat back, here you're going to have to deal with the deformity up here potentially, but you have to think about how that's going to affect your spinopelvic parameters, and this is going to probably lean you away from a correction there and back down in this area, even though it's ankylosed. So if you have a significant thoracolumbar deformity and a lower lumbar deformity, maybe you have to correct in 2 different places. Beware of, and the more complex the deformity there is, the ripple effect of what you do on the spinal pelvic parameters. It's where these planning software programs are very helpful, because as you change certain areas, you'll impact things that are hard to prognosticate without going through the math on it. And this is kind of a key thing to remember. Just keep in mind that wherever you do your big correction, you're going to affect your pelvic tilt less substantially if you do it in the upper lumbar spine or thoracolumbar spine versus the lumbosacral junction. That's why an ALIF at the 5-1 area is so powerful. So when you're making a decision after you've figured out where you want to do the correction to potentially do an ACR, scrutinize these sorts of things ahead of time. Have they had an infection there? How inflammatory is it? Endometriosis can be a tough one. Really severe modic changes or inflammatory processes make it hard to sweep everything off and distinguish annulus versus the sympathetic chain. And so it's not a deal killer, but just beware it can be tough on the exposure. I tend to like to have CTs on these cases for planning purposes for a couple reasons. One, it gives you a much better appreciation of where osteophytes like this might exist, and you can see where it's going to be difficult to migrate under the vessels or between the vessels and osteophytes. Occasionally you'll have osteophytes that are sitting like this and the vessel's sitting in between and hugged, and it's very difficult to weave your way between the vessels and the phytes. That's one to probably bail on and not try to attempt. Prior vascular surgery, and then we talked about before this anomalous vascular or urologic structure in the region that you're going to expose. And the other thing to keep in mind is just because you have a cava that might be sitting over in this corner doesn't kill the deal. It just moves your strategy. Tactically, you switch from going from the left to the right so you can safely retract the cave out of the way and you're not blindly going at it. In fact, I often will do ACRs from the right because then I don't have to worry about the far corner at all for that very reason. Review the MR axials as well. It's a little easier to see the fatty plane relative to the CT scan, but you want to try to find a nice fatty plane between the vessels and the cava. This is a good situation that I would suggest going from the right side, so you can safely get under the cava and in no way strike it coming across with an instrument that you're trying to dissect with. And if you're coming from this side, from the left side, it's very difficult to actually see that structure around the corner. So rather come this way, and then you can very easily sweep up and under. The side of approach we just talked about, I don't think we need to beat that up very much. It does get affected by the scoliotic nature of the patient you're treating. If you're treating both a scoliosis and a sagittal deformity, then the concavity of the curve is often the place you want to be. Fortunately, that's often the right side, but you have to decide where your priority is. Safety of the vessels comes first. And the other thing to keep in mind with ACRs with coronal deformities is it's a very powerful sagittal corrector, but it doesn't do much for your coronal alignment. So if you're trying to correct a sagittal malalignment right in the middle of a scoliosis, you're basically going to kick the spine off in the wrong direction if it's kind of a compensatory curve above a fractional curve. Does that make sense? So let's say 3-4, 2-3 is the center of the cob on the coronal alignment, and also where you think you need to get your sagittal correction. The minute you stick that cage in this disc space that's coronally imbalanced by design, you do this and the spine takes off from there. It's very hard to correct above that. So you have to be thoughtful about how you plan that out, because we don't have coronal and sagittal realignment cages. So they'd be tapered in both directions. Be nice, but they're not available. I'm not going to talk too much about the technique because Juan and Bill did such a good job of that. I'll throw in a few of my nuances. You got to get way back in most patients. These things fish mouth open. Between the trial and the cages, they want to migrate forward, even with the guide that comes down the posterior blade. So getting pretty far back, as you see with this red arrow, is critical to success, and then efficiency as well. I tend to use the box cutter like Bill. I think it's a little bit safer, but just try to get your wide, there we go, the wide retractor in, so it really covers the anterior disc space, and even track yourself down on image along that blade. The curved blade, as you see down here, I don't know if everybody can see that, but these anterior retractors have a curve on them to kind of hug the anterior body. Those sometimes aren't very easy to get across, depending on the depth of your lateral wound. So at the minimum, get the straight one in, make sure it's far enough across that you believe it to be beyond where the vena cava is if you're working from the left. If you're working from the right, it tends to be less of an issue, but you have to extrapolate from your pre-op imaging in terms of how deep you get that retractor, and that should keep you safe. The wide one also keeps you from dropping into the disc space. Otherwise, the technique's similar to what we already talked about in the other presentations. Other little tricks of the trade: when you have the ACR cage, or a realignment cage like this, it has to have some sort of fixation mechanism. If you have the tabs, you can't use your slides and other things to drop that cage in. And if you use any kind of morselized graft, usually the space is pretty floppy, but it does take a little malleting, and the graft can reverberate out of the windows of the cage. So I usually just use Surgisil, one layer of film of it, wrap it around the cage where the windows are. So be wrapped right around the circumference of the cage right here, and then a little vicryl suture to hold it in place, and that captures the graft as you're pounding it in place. All right. I want to go back to that. So back to where we see troubles with ACRs. Not much different than with PSOs. 6 months to 2 years, you can see rod failures because of the destabilizing nature of both an ACR and the posterior column release. we tend to encourage 3 or 4 rod constructs across those sites where you do such a dramatic release of the spine. There's just cyclic loading that goes on for probably 6 months while this thing's healing. It's got a lot of span for bone to cross before it takes a load off the fixation. So 3 to 4 rods are our standard practice now. If you don't release the back, then I don't think it's as critical that you do that. The other thing to keep in mind is the higher the lordosis, the 30 degrees in particular, can swing your superior articular process into the foramen. You're doing this kind of thing. So if you're using a higher rated lordotic cage, pay more attention to the posterior height of the cage, which may keep the swing from becoming relevant because they're more like this instead of closer together. But if you use a 30-degree cage and you put a 2 millimeter height in the posterior aspect of the disc space, or the posterior height of the cage is small, the posterior walls kiss or nearly kiss, and the SAP and the IAP will basically swing into the frame, and you can get a pretty nasty ridic you got to go after. So if you're not planning, or you don't think you may need to do a posterior release to get the correction, be thoughtful about the posterior height of the cage. That's one of the, we're looking at angle and posterior height. We almost never pay attention to the anterior height, just as a matter of intraoperative designation. And then if you have to, if you want to keep it MIS, you have the luxury of doing fancy stuff like this, where you can do midline skin, you can do paramedian skin, however you slice it, but you can be a little less violating, even in the case where you have to do a posterior column release, as you see here, or even a massive correction. You can do a mini open PSO and an ACR and get your 60 degrees of correction with a pretty elegant, fully minimally invasive approach. So a couple examples, both of when to think about it, when not to think about it. Think about doing an anterior column release. This is a 78-year-old woman, a little bit of a medical disaster. Failed non-surgical management, was placed on Forteo, and then we embarked on trying to fix this mess. You can see here on the preoperative imaging a fairly substantial mid-lumbar kyphosis. So this is where I'm starting to think this is a good case for ACR. There's no point in trying to get correction at 5'1". She's already hyperlordotic really there as a corrective mechanism. Obviously, you want to make sure on your axials that these are not obstructive and that you have room in front of those areas to get under the vessels with a fatty plane, which we did. So we put her through a 2-stage operation with a ALIF at 5'1", not for realignment, but for structural support. Laterals 2 to 5 with an ACR at 3-4, and then a second stage 2 days later, which was open with posterior column osteotomies 3 to 5. So a lot less aggressive approach than I would have otherwise had to use, and you can see the realignment capacity there with the 3-rod technique. And then another example of kind of a different deformity. This is obviously postoperative deformity. Had an infection after multi-level, he's had more than one surgery obviously, but had multi-level TLIF, all of which are pseudoed, got an infection, kyphed above the TLIFs that you see from 1 to 4, and has a 5'1" adjacent segment disease as well. So, show you some advanced imaging. There you can see a thoracolumbar kyphosis, which is a bit flexible, but perhaps a little closer to ankylosed at that section, and then 5'1's collapse. So 2 areas of deformity, and then 3 levels of pseudoarthrosis and a prior infection. Not a great situation. Not a lot of bone in the back, kind of wasted away in the back from the original surgery. So this is basically deploying a full ACR armamentarium at the base at 5'1". We got some good correction. We did a thoracolumbar retropleural approach at that area of maximum kyphosis at the thoracolumbar junction, and then these laterals are revision laterals without ACR, because that wasn't necessarily a deformed part of his spine. So you can see we got him back in reasonable condition and a nice harmonious lordosis. Another patient, reasonable to consider, 69-year-old male, also medically a bit of a disaster, but nonetheless had decent bone. And you can see here, multi-level disease, had a prior ALIF, which didn't help him, obviously. And we did multi-level laterals with ACRs at 2 levels, and you can see the correction. All right, now I'm going to jump to a situation where you need to be thoughtful about not using it. This is a woman who's had probably some ill-advised surgeries. You can see here on the left, multiple different surgeries, different fixation methods, and a grossly sagittally malaligned situation. 50-degree mismatch and a huge pelvic tilt, so she's really trying to compensate maximally. You can see a thoracic spine that's trying to lordose essentially to make up for what's lost at the base, but a fixed spine in the areas below the screws. So, you know, in yesteryear, we might have initially considered, well, maybe we could go in at this level and do an ACR. But remember the implications of where you do the ACR, where you do the correction on the remainder of the spinal pelvic parameters. And you need to drive all of them into fairly normative situation. If you leave the pelvic tilt at 34 degrees, it is an independent driver of disability. So we want to try to correct that, which, if you look at her disease process and try to get in to any one of these levels, even if you were thinking for a moment that, well, maybe I'll take down these old levels where there seems to be some disc. If you didn't notice, she's got vascular grafts and all this stuff in the front. Not a great anterior approach down there anyway. So we opted, based on the need to correct her tilt, to go low in the lumbar spine, abandon the ACR thought, and correct her more aggressively where she needed it most. And so you see what that looks like. And this gives us a much more harmonious lumbosacral junction, L4 to S1 alignment, and she's done well for that. So in summary, be thoughtful about ACR being a powerful tool, but where you utilize it will have profound implications on the patient's success and outcome. Really careful planning with your imaging, much more than with the laterals. Know what you have to do with respect to putting the retractors in position, and that it's not, you're not just stopping at the anterior superficial margin of the annulus. You got to get all the way across, and you have to know you can get there. The parameters that you're trying to correct, all of them will be variably affected depending on where you place the ACR, and you may need to do a PCO on the fly. You may have to do more or less on the fly. Be prepared to adjust the plan. I find that the hardest part of MIS deformity surgery. Sometimes it means I have to open it up when I didn't want to, and sometimes I can shut the open plan down because the spine gives me what I wanted from the anterior column. That's tougher on the system because you can't get the OR all set for, okay, we're going to do the ACR and then flip and do an open T10 of the pelvis. They have to know. We have to see how it goes. We may be converting our plan fairly aggressively even the day of. And provide ample posterior fixation. It's very destabilizing, so prepare to put 3 or 4 rods in. And that is it.